Welcome to our monthly Lunch and Learn. A small crowd today, but I'm glad that you guys are here and hope you enjoyed lunch. Yes, absolutely, absolutely. Always learn something new at Clearview. So today we have a very special guest with us today, Dr. Angel Farinas. He is a general surgeon on staff here at Clearview, and his practice is with Georgia Surgicare. And they just do all sorts of really neat, new, and innovative procedures with their patients to treat different symptoms and different conditions. So whenever there's something new out, I usually know that these guys know something about it, which is cool. They're always on the cutting edge of technology, which is a great thing. So today we're talking about heartburn. Anybody experience heartburn? Who doesn't, right? Yeah. Exactly. So, you know, with heartburn, there's so many different treatment options, and this is a new, kind of a new one. It's semi-new. Yeah. But a great way to avoid some of the other complications that can come with some of the other treatment options. So, without any further ado, I'll turn it over to you.
Thank you, Emily. So, the topic that we're going to discuss right now is GERD, is gastroesophageal reflux, and heartburn, but this is an option for treatment, okay? If you could click the first one. So, GERD, what is GERD? GERD is basically the reflux of the gastric content into the esophagus, okay? And it usually has to be chronic, and it usually, all the contents of the stomach go back into the esophagus. And you can see as a presentation there, or the depiction of the image, where the contents of the stomach should be and the junction between the esophagus and the stomach. So everything should stay down in the stomach. Nothing should go all the way up to the esophagus. Okay, next one. So symptoms. Everybody has experienced heartburn. And we basically, when we talk about heartburn, we have to divide it in typical and atypical. The typical is the basic things that whenever you talk to anybody, says, oh, you definitely have heartburn. Basically, chest pain, excessive salivation, metallic taste in their throat, sensitive to some foods or liquids, especially like alcohol or caffeine or even chocolate. But then the problem is that you have the atypical ones. It could be any complaint, and usually we see this a lot with people that go into the ENT. Oh, I have problems with sore throat, or my ear hurts, or I go to the pulmonologist. Oh, I'm having difficulty breathing or difficulty sleeping, and then at the end, other things that could also happen is cardiologist. Oh, I'm having so bad chest pain, and they do all the workup and they don't have anything. The main problem is reflux, okay? So these are the people that they don't really know that they have heartburn, and they have all these atypical symptoms. One that is very, very common is hoarseness, because all the reflux just sprinkles on the larynx and it produces this type of voice, okay? Next one. So this is just kind of like what could happen with reflux, okay? We have the typical clinical presentation that is, the heartburn, regurgitation, and the atypical that we already talked. But if you don't treat it, you become symptomatic and you could produce inflammation in your esophagus, and then that's not that problematic as complex inflammation. And when the complex inflammation happens, or the chronic state, is you could develop ulcers, hemorrhages, and even cancer, okay? So the one thing that you want to prevent is all that sequence, okay? Next one. So you're gonna see on these presentations a lot of numbers that you shouldn't pay attention. I'm just gonna tell you the conclusion about all those numbers. Here we could see that from 1975 to 2001, the esophageal cancer that is correlated with reflux has increased significantly. And here, what you see is that incidence and mortality has increased a lot because you've seen that it's left untreated. Okay? Next one. Another slide with numbers. 80 million, and half or a quarter of the Americans have GERD. You see it, it's very common. on TV, and it's even over the counter right now because it's so common and it's been so well studied that they make it so easy access for people. And guess what? You know, we tend to do not the correct things to treat GERD, so we do all the opposite. And if you have a pill for that, great, let's treat it. The other thing that you could see in this slide is that quarter of the Americans have this problem. 10 million only visit the doctor for this problem. 6 get a test to get the diagnosis, and only 30,000 get a surgical procedure for this treatment. So basically, from 81 million to 30,000, that's a pretty significant small number. Okay, great, next one. So how does reflux work? And to explain a little bit of how reflux works, I'm going to show you a normal image of what the anatomy should look like. You could see that that is the esophagus on the top. The big bulge like that is the stomach. It has to have that sort of a valve that it's right here, and it should be below the diaphragm. This is a negative pressure, and this is positive pressure. Anything that, if that junction goes and sneaks up a little bit into the diaphragm, then this is going to act like a vacuum, okay? That's exactly what we try to do with this procedure. Try to recreate that valve and make sure that the junction between the stomach and the esophagus is at least below where the positive pressure and doesn't act like a vacuum, okay? Next one. So this is more of like a correlation of what the regular anatomy looks like when we see it with endoscopy, and what is a dysfunctional one when we see it on endoscopy. In the upper picture, you could see how the normal anatomy, see how tight that valve is below that diaphragm. And that means when you see it with the scope, you see that little lip around the scope that creates that sort of a valve and that tight pressure. When you compare it to the next one, you see how that valve below the diaphragm is open, and things just could swipe and go up and produce the symptoms. When you see that picture, you see that there's a space between the scope and the tissue, means that the valve is not existent. And think about it, it's like doing one of those pastry bags. If you fool the pastry bag and then you just squeeze it on the top, it will go preferentially and you could put the icing on the cake. But if you have a really floppy valve on the top and you leave that bag open with all that cream on top, if you press it on the middle, it's just going to create a huge mess. Exactly the same happens with the stomach. Okay, next one. So what to do? You already have symptoms. You have a typical. We already know that you have symptoms. This is the spectrum of the treatment. What to do? Lifestyle changes. Great. Nobody can do that. You have to be so strict on doing it. You can't do coffee. You can't do chocolate. You have to eat 3 hours before you go to bed. Yada, yada, yada. Too much frequent meals. It becomes very difficult. People that are very disciplined even fail doing that, because I see them all the time in the office. Pharmaceuticals, we already talked about it. Omeprazole, PPIs, all that. It's really easy. It takes care of it, but people now these days want to get rid of one extra pill that we were talking about. And then you have the other problems, that the other solutions, that it's surgery. You do the conventional surgery that is doing, incisions and cutting, and we have the procedure, the TIF, that it's without all those complications. Okay. This is a great slide because this will answer all the questions that you were asking me about what is the complication of being so long with omeprazole. And the most important thing is that increases the risk of what we call C. diff colitis. It's an infection in the colon that attacks mostly people that are kind of with low defense, and it could be a very mild thing, or it could be a very deathful thing. Right now, people that are in the hospital will trying to put them on omeprazole to prevent this, because people that are in the hospitals are more prone to have this condition. But we're seeing now in the community that they are getting this type of infection. The rest of all the things, increased risk of pneumonia, osteoporosis, increases the risk of osteoporosis too. And the other important thing is that increases the amount of polyps in the stomach that could become malignant too. Okay. And down there is all the data and all the studies that are backing up all that information.
That's gastric polyps or
gastric polyps.
Colon polyps.
Gastric polyps, correct. Correct. Next one. So when we have a diagnosis of reflux, there's several things that we need to do. One is the pH testing that measures the amount of acid that goes into your esophagus, and that's the most important one because that quantifies how much acid is in your esophagus. But we have other things that will tell us a lot about how your esophagus and your stomach is working and if all those things are contributing to your reflux. Sometimes all of these are normal, okay? Those are the best candidates for TIF, okay, for our procedure. So what have we done with this type of procedure and where are we standing with this type of procedure? We've had 50 peer-reviewed papers already. The experience is in over 16,000 patients. And it all started in 2007, but it got more, I would say, speed on 2010. The outcome is that we've noticed that all of them have the same effects as the surgery, which is great. And the other important thing that we have to think about is safety. 0.4 is the amount of complications that happen in general with this procedure. Pretty small compared to the open procedure. Next one. Loaded slide, I know, but this is so you could understand what does the TIF do. 75% are completely off of PPIs. The rest of them that is above the line uses episodically. For example, yeah, I shouldn't have eaten that chili dog. You have the PPI, okay? You eat the omeprazole. That's fine. That's also a good outcome for us. If you use it eventually or episodically, that's a great thing. But you're at least not using it every day. And if you don't take it, you have symptoms, okay? The other important thing is that 85% of the time, we see that their inflammation of the esophagus, because having a lot of acid against them produces some sort of inflammation. After the procedure, 85% of them are completely healed. So remember that sequence that we talk about, reflux, esophagitis, even going to cancer, we stop that sequence right there, okay? Now, how does this procedure work? If you see the inner part and the part that is bending like that, that's the regular endoscopy that we use to diagnose and treat. The device goes on top of the scope, and basically it folds on itself, and you're actually seeing everything happening right there at that same time. And usually what this does is go from that dysfunctional valve to create a normal valve like this one, okay? If you put the next one. So this is kind of like a representation of what it should look like. So you see how the instrument is trying to create that lip or that valve, and if you see it from in this picture here is a fastener. It looks like an eye. One part of the eye is on the esophagus and one part of the eye is in the stomach, and just basically just cinches it up, and your tissue is your same tissue. We're not cutting anything, we're just putting things together and make sure that we recreate that valve. Those are made of non-absorbable material, but it's completely harmless for the body, okay? You actually go after a while, after 2 years, and you could see those things still hanging in there, which is a great thing. So, and this is what we see before and after the procedure. This is one before, when you see that pink kind of colorish type of flame like that, that's the junction between the esophagus and the stomach. Now, once we do the procedure, we recreate that valve. So see how now is kind of snug to the esophagus, to the scope, and prevents everything to go the other way. Okay? This slide, what tells us is that what does the procedure do compared to the regular one, the surgical one that we do. And if you look at it, everything that the open procedure or doing it with the laparoscope does, reduces the hiatal hernia, elongate the esophagus, produce the fundoplication, recreate the dynamics, restore the high pressure zone, everything the TIF does, except repair a hernia that is more than 2 centimeters. And those are one of the contraindications that we have, and those are one of the major things that we look for to just kind of filter who needs this operation and who needs this procedure. So all of the milestones that we need to do to treat reflux are met with the TIF, except that, okay? Because it just makes a little bit of sense. If the hiatal hernia is big, there's really difficult way to put the fastener to the esophagus and the stomach because there's a lot of space. So that will be a really strong contraindication. The rest of them, we could discuss about that later. Next one. So these, after that, we just need to talk on who are the patients who cannot have this procedure. And basically, if we think about it, patients that have the hiatal hernia, if they have a hiatal hernia that is bigger than 2 centimeters, or a paraesophageal hernia, that they're the same kind of thing. Just imagine that if you have a big hernia, it's going to be really hard to do this procedure endoscopically. And other things, sort of like severe esophagitis. The reason that severe esophagitis is because there's a lot damage already, and we are not sure that that is going to progress. So there's not been too much data with it, so that's why we try to prevent on doing those people. Those need a surgery and need more surveillance. But it's just because it's we're a little bit careful with that. Bleeding disorders, of course, and things that are wrong with the esophagus, such as varices, infection, or strictures, because then they're going to need more procedures to treat that GERD.
I noticed chronic cough up there.
That's a relative one. Usually the chronic cough is because you need to intubate and put the device in. So those are things that are kind of difficult they're not very set on stone. And the other thing, because most of the people that come in and have laryngeal component of hoarseness and everything, they also have chronic cough, and they are a good candidate. So it's a little bit difficult to put in that classification of like, oh, you can't have it. Mm-hmm. Not like the hiatal hernia. And the other thing is that people with larger BMIs or obese, they have to be a cutoff, and we say, well, above this weight we can't do that. But now people are trying to push a little bit the limit, so things are kind of like, trying to rewrite all these contraindications, not as much as an anatomical one like a hiatal hernia. So it has to be tailored to the patient.
So basically the first thing you have to do is have an endoscopy.
Correct. So you have to have a lot of tests, and that's one of the slides that I there. When we're confronted with these type of patients, we go and, depending on, for example, in his case, the Senker. In the Senker, you have to, if you have confronted a patient with Senker, or you think that he might have a Senker, you probably do an extra test. But yes, the next step that we do is an endoscopy to make sure that there's no anatomical things that could preclude you to having this. And the other thing that we do is the Bravo, that it could measure the amount of acid, and that gives us more of some sort of evidence to do the procedure. For example, let's suppose that I go in and do an endoscopy on you and your anatomy is completely normal, and then I do a Bravo that is just putting a device on the esophagus and measuring the amount of acid that goes there, and the amount of acid is 0. I would say, you know what, I don't think your problem is because of reflux. Okay, and then we'll do a manometry, and the manometry is completely whacked, and say, well, you're not a good candidate for this. You know what I mean? So it all depends. But basically, the two main ones that we do is the endoscopy, correct, and what we call the pH testing or Bravo to measure the acid in your esophagus, correct. And those are things that are done outpatient-wise, and we try to do it as fast as we can just to make sure that we get, because what we've been noticing is that patients are kind of impatient. So we were trying to actually do a complete full stop in our office to have everything done. So they get in, it's like, oh yeah, and then it goes to station by station by station, and when they leave, they already have the surgery data, and they're all happy. Unfortunately, we cannot do that, but we're trying to make sure that we do the diagnosis and the workup fast in order for you guys to have a faster, recovery. So that's mainly the idea. All right. Any questions besides that?
Okay, what, if any, are the side effects from this particular surgery?
Great question. We've noticed that one of the most bothersome one is bloating. And what happens is that if you think about it, it just takes time to get better. If you have a valve here and the stomach is just getting used to the new environment, it's going to push air that way, and because it can't go that way, you feel a little bit bloated. You will notice that it will get better with the things that you eat and with the things that you do, and in time gets better. It's only proven to present in 0.4% of the time, so it's not very common, but some people complain about that. But you see, so then you get the lesser of two evils, correct? Then you're like, what about your reflux? Nothing. And are you off the members? Yeah, I love it. So they kind of balance a little bit, correct?
But that's basically the only side effect that you've.
Yeah, well, there's a lot of them. There's like bleeding, ulcerations, and all that don't really happen. And what I was telling you earlier, that we, as a small practice, and right here, we have a vast experience because we have a lot of procedures done under that, and they usually don't have as much complications as the surgery type, because the other ones develop wound infections, hernias, and this one is just, you go inside, you do it, and there's no wound check, there's no risk of infection, nothing. We noticed there was one patient, but this is kind of the outliner, that he had the procedure done and he had a car accident. And he was a bad car accident, and then after he spent a lot of time in the hospital, and after a while he started developing reflux symptoms, and then he came, we worked him up, and what happened, he blew it up. But it was very recent after the surgery, and it was very unfortunate. The good thing about this procedure is that you always have another option, because we're not cutting, we're not doing anything. So he was a candidate for the other wrap, so you're not burning any bridges with this procedure, which is a great thing.
What if you don't have all those symptoms? Now, I've had it so bad, if I went to hospital thinking I had a heart attack.
Correct.
And they finally said I had
Reflux?
reflux.
Correct.
Okay, and I get it sometimes when I lay down at night. I
Correct.
have to lay flat on my back with my head propped up.
Correct.
I can't lay on either side because
Yeah.
fluid comes up.
Uh-huh.
Now, I've had them to go down in there and check my esophagus, my stomach, and I have no cancer and no,
No anatomical problem, no hernias, no nothing.
Right.
Yeah. To me, you sound like a great candidate.
Right, and I've even had a swallow test because ever since I had that throat cancer,
Mm-hmm.
and they give me so much radiation and chemotherapy
Yeah.
from a thyroid gland and my saliva glands.
Correct.
And I couldn't taste food for a long time,
Sure.
so I went and had tests done. They had me to drink stuff, eat stuff, and showed it on the thing.
Mm-hmm.
And said my valve and everything was working fine, but if I take too big a bite, it just wants to go up my nose and
Mm.
sticks in my throat, and I constantly cough. And you probably noticed I coughed a little bit here a while ago.
Sure.
because of it.
Sure.
Now, would that dictate having this procedure, or would you do a test and see?
We probably will like to do more testing, and I will probably do a manometry to make sure that your esophagus and everything is, working the way it should, because there's sometimes the problem is not down here, it's up here.
Yeah.
And people complain about all these things, and sometimes if we don't do the correct workup and we do this, then it could get worse, your symptoms. So I would say in your case, I would do a manometry. If that is working fine and if that is working okay, then you probably will be a candidate. We'll have to just do a lot of further testing, but sounds like you could be a good candidate.
Dr. Bernard recommended, what's that pill I take? The red and green pill, ain't it?
Okay, that narrows it down a little bit.
Anyhow, I gotta take that every morning.
Correct.
If I don't, I have a problem. Sometimes if I eat spicy food or
Yeah.
something, that don't help. I have to chew up some more additional pills.
And that's basically the problem, is that's one of the biggest complaints that the patients have, and sometimes it's just that extra pill or extra, that it just saves you out of trouble. And now imagine that you could do a procedure and you don't have to do that. That makes it a lot of difference. Correct.
What if you do have a small hernia, hiatal hernia?
You could have it up to 2 centimeters,
Up to 2
and it's not too bad. If it's up to 2 centimeters, that's not too bad. Thank you so much. And and actually this TIF procedure corrects it. But if it's above that, then we tend to do it robotically, and it's from the outside, which is a good procedure too. It does the work too, but it's, when you tell them, well, we could do something without cutting you, and they're like, yeah, I want that one. So if you're a candidate and if there's no contraindications for that, then yeah, I would say, yeah.
Now, how long after a procedure like this would you be able to start back eating?
That's a great question. We usually have a protocol, and it's a diet that we use, and we kind of put you back to just liquids for some time, for some days, then advance you to a full means that it's everything liquid that you cannot see through, and then we give you soft food like puree diet, and then a little bit more consistent, and then we grade you or graduate you to solid foods. And usually all that time, it takes 6 weeks. There's 2 things that happen with that. People lose approximately 10 to 15 pounds.
She's like, sign me up.
That's the reaction of everybody. They love it. And not only that, is that they kind of like feel a little bit better. So we're trying to reduce that time to 6 weeks, because we've noticed that they kind of stray a little bit on the diet, and they kind of like cheat, which is okay, which is fine. There's tricks that we teach them how to do stuff. For example, the biggest things that you're going to get into trouble, it's meats and bread. So then we tell them to just cut them very, very small and just chew it very well, just like you were saying. And that will save you getting into trouble. But usually the amount of time, it's 6 weeks. Yeah. And you do the procedure, you stay overnight, and then the next morning we send you with all the specific things that you need to do. And actually that's kind of evolving too. We used to wait 2 days, now it's 1 day, next couple of months is going to be the same day. It's evolving, let's put it that way.
You didn't have a real physical strenuous job, you'd probably go back to work next day, didn't you?
Correct. The only thing that we think that it could get you into trouble will be heavy lifting. But the rest, and no car accidents either. But otherwise, yeah, and patients feel normal, feel fine, feel like they didn't have anything done. There's the outliers that that have a little bit of pain and so forth, and they're a little bit. Pain is such a sensitive or subjective thing, but most of them they just feel great.
Yeah, I've noticed if I eat peanut butter and stuff,
Yeah.
too late at night,
Yeah.
that's a big thing.
Yeah.
If I eat bananas and just go out normally working, that tears me up.
Correct.
I've cut out just about all bread. I eat more bread right here than I normally
Yeah,
eat.
I know. Taking care of GERD is like taking care of a gremlin. You can't do this, you can't do that. No feeding after midnight, no water. It's just because it's difficult,
Yeah.
and people just don't want to do that.
Yeah, just plain water causes it on me sometimes.
My twin sister has it. She just drinks water.
Really, I imagine. She's begging for it. She's begging for the procedure.
She was supposed to come today.
Oh.
A friend died and she had to go.
All right. Well, you'll give her the whole information.
Yeah. Everything I've learned.
Correct. But there's options and there's solutions, and before, back in the day, Dr. Nissen is the one that created this type of procedure, and before it was an incision from ear to ear, and wound infections, hernias, very morbid, a lot of pain and a lot of everything, and now you don't even have to cut the
It sounds
patient.
good.
It's a great deal.
It is.
So
You gonna try it?
Is that covered by Medicare and your supplemental?
yes, yeah. Just have to go and it's going to make it easier when you guys come to the office, because we really don't have to talk about much. So it's just basically, hey, how's it going?
You gonna give us your card?
Yeah, definitely.
Yeah, I'll give you my card as well. I'll just staple them here. So right here is the number to Georgia Surgicare, Dr. Farinas' office. So
Okay,
the next step would just be to call and make an appointment to come in so that we can do the workup and the diagnosis, just to make sure that you are a good candidate for
Is
it.
your office here in town?
We have one in Monroe that we do every Tuesday. That you could, if it's more convenient for you, then yes. Yeah.
Otherwise, just a hop, skip, and a jump to Loganville.
Correct.
Yeah, I ain't got no problem going to Loganville. Or even Athens, so I just wondered where your brother was.
Correct.
So if you have any
Right on
questions or
78
you're having
there.
trouble
Correct,
with
correct.
office, just
Well,
call
thank
me.
y'all so much for.
I have another question.
Go ahead.
Sure.
This is change the subject, but we were talking about famotidine.
Correct.
What was an earlier pharmaceutical with a similar name?
Ranitidine.
Ranitidine, that's right.
Ranitidine used to works in a different area. The problem is that the studies when the what we call proton pump inhibitors, that is omeprazole or Nexium and all that, and famotidine came out, they compared it to ranitidine and see who had better outcomes. And the proton pump inhibitors, the earliest ones like omeprazole and all that, they had better outcomes. That's why you can't really see ranitidine
Sorry,
anymore
Do you have
because
appointments, say,
nobody
around
orders
2
it
later?
unless you're in the
Oh,
hospital and
appointments
you
later.
use that in the
Oh,
hospital.
Ah, you don't
And
know
there's
that
people
stuff.
that have
Yeah,
so
it's
severe reflux
call-
that
this
we
is his office
give them
number,
both
Georgia Surgery
treatments
Care.
too.
Just call this number.
So, but
and say
yeah, you're
that
right.
you
That's
went to the seminar
decreased
for
in
reflux
favor
with
for a
Dr.
long time.
Farinas, And that
Yeah.
you want to schedule an appointment.
Well, I
This
certainly
is
do
my
appreciate
number.
y'all coming today and being a part of this. Hopefully you learned something new.
Absolutely.
And take
Yeah.
this information and share it with other people that suffer from similar things. It's a really neat new procedure that really can help a lot of people. So we want to try to get the word out as much as we can. So thank y'all for coming and thanks for tuning in.
Thanks for
Good
the
lunch.
lunch.
Thank you. Thank you.
Absolutely.